Yeah, hi, I'm Donatella Massai, the Senior Technical Lead of the READY initiative. I am joined today by Leung, who's the Regional Migration Health Specialist for the International Organization for Migration, IOM, Regional Office for South Africa, based in Pretoria, South Africa. She has been previously worked in the field of public and migration health in the Asia Pacific, South Asia and Caribbean region, and has been part of the response team for outbreaks and natural disaster, including 2010 cholera outbreak in Haiti, Ebola outbreak in DRC, and the earthquakes and cyclones in Mozambique and Nepal, among others. We are here today to talk about community health programming and the adaptation to COVID. Keith, would you be so kind to share with us your experience in the sexual and reproductive health and HIV No Border program, and what was the adaptation you did for the COVID pandemic?
Great, thanks Donatella. Yes, more than happy. Thanks for having me. I guess today I wanted to focus on the, as you mentioned, the HIV SRH, our Knows No Borders project that we currently have here in the Southern African region. So it's an initiative that we've been implementing for some years together with Save the Children and the University of Witwatersrand here in South Africa. Really looking and focusing at promoting sexual reproductive health rights amongst young and vulnerable migrants and migration affected communities. So in essence, it's a community-based initiative. It's active mostly in border areas, but also other urban areas that receive a large number of migrants, including cross-border and internal migrants. Just to explain a little bit about the model further is, from the beginning, we've had quite a large workforce that are community health volunteers, or we call them community change agents or activists, who have really been the backbone of the project. So their role is really around, health information and education, behavior change communication, working together with other migrants and migration affected community members to make them aware of their rights. And particularly with this population, they focus a lot on referral and linkage to health services. We work with a very mobile population that obviously might touch on different, might move across borders at various points and be in different communities. So they really provide that strong linkage back to health services. They also provide a wider role in advocating within the community and within local government and national governments for the rights of young people and migrants in sexual reproductive health and HIV. So they were in place, prior to the pandemic, and obviously here in the Southern Africa region, we had probably one of the most severe restrictions around mobility, which really affected both the way that we operated, but obviously at the community level and how they were able to respond to the situation that they were faced with. I mean, migrants prior to this faced a number of vulnerabilities in accessing healthcare, whether they be physical barriers in distance, whether they be due to, their immigration or irregular status that deny them of services or create barriers for them to access services, or whether it be cultural, linguistical barriers in accessing those as well. So we saw many of these not only be intensified during the COVID, but obviously working with a very mobile population that are reliant on mobility to support their livelihoods, but we also know to support certain health aspects as well. For example, we had a situation after the pandemic started where, we found a lot of migrants who were used to traveling to access their ARVs, for example, or TB medication, that often move back to their home communities to access that medication, or the reverse. We looked at the case of mine workers from Mozambique who preferred to access their treatment in South Africa. And when the lockdowns began, they were then sent back home and stuck home, and then having to reach out to healthcare services for TB treatment and HIV treatment that they weren't used to. So there was a number of impacts in terms of the COVID pandemic on the way our populations that we work with were responding. And I guess your question, Donatella, is how did we adapt? and how do we work around some of these challenges. So I guess firstly, it's always safety first in terms of for the volunteers and the staff that we work with at the community level. So it's not only change agents. I also need to mention we work heavily with local health service providers, but we work with a lot of other sectors. Working with migrants requires the involvement, for example, of immigration officials, of police, of security forces. With this particular population, we work a lot with departments of youth and social development. When we work with older migrants, perhaps migrant workers, for example, we work closely with labour. So at the community and the district or provincial level, we're engaging with all these partners, and obviously the first concern was their health and safety. And so training, support on basic COVID infection prevention and control, provision of PPEs was necessary. But then again, we had to also look at incentives. And that's really important to recognize that sometimes those incentives change. So for example, in the case of community health workers, we saw a greater demand for or interest for support around data. So one of the adaptations that we did is while these community agents would usually go door to door or conduct community events, because of some of the restrictions, they were unable to do so. So we did rapid training for them in how to navigate and use social media to spread some of the messages that they would normally do face-to-face or in the community. So with that, we decided to change some of the incentives to give them phone, mobile data, so they're able to do their job better. And really in a time when people are stuck at home, I think mobile data was seen as being not more valuable than other incentives, but highly critical. So that was one of probably the second adjustment that we made to our programming. And then obviously blending programming. And I think that's what partners, everyone can say is they've had to take on new aspects in the way that they deliver their services. So where we would be doing health promotion around sexual reproductive health, we were blending that with COVID messages. In some countries, so just to mention that this initiative's across 6 countries, we were also blending TB programming with HIV programming with COVID programming. So for example, where we had teams going out to do active case finding for TB, they started to add on to that active case finding for COVID as well in conjunction with local health authorities. So we did see a lot of blending, and that's really just to respond to the needs of communities. I mean, when we say respond to the needs of communities, we also have a number of mechanisms, so community feedback and rumor feedback mechanisms, to inform us of what people are concerned about and what they want to hear about. And increasingly, you see the kind of interest in HIV, sexual reproductive health may not be in the top view. Instead, food security, livelihoods came up very high, followed by information around COVID. So we had to adjust the messages that we delivered as well. Locations, they changed as well. I mean, before we were working a lot with schools, obviously they were all closed. So we had to look at where people were now circulating or congregating and move our activities around that as well. So for example, in South Africa, I know soup kitchens became a big focus. I think in other countries, for example, as we saw return to work initiate, we saw some changes within the sector. So for example, farms, construction, mining, those sites moved a little bit depending on who was allowed back into the country and able to go back to work. In terms of treatment, we saw, and many governments were very proactive, but there were challenges in rolling this out, particularly at the district and community level, was multi-month script filling, particularly for HIV. I think some countries moved from 3 months prescription filling to 6 months, and TB to the extent that was advisable and possible as well. So, it's important to recognize that many of these decisions can be made at a central level, but to support people in accessing those at the community level is really important, particularly in the border areas that we work as well. Maybe just one other area to highlight in terms of the way that we've adapted as well is, as IOM, the International Organization for Migration, we also have a number of tools in which we use to map population mobility trends. And I think that was highly useful to understand how trends in movement were changing as a result of some of the restrictions, but also the socioeconomic factors that were at play or continue to be at play during the pandemic. So we had a number of mechanisms to regularly collect data in terms of where people are moving to and from and their motivations for movement that enabled us to refine how we targeted our interventions. I guess what's important to point out is that the role of the community in these data collection mechanisms and uses is highly useful. So I'll give you the example, for example, in Mozambique, which is one of the countries as part of this regional initiative, for example, was able to use key informants at the community level to be able to identify households that were receiving migrants coming in. So again, linked to some of the border restrictions, we saw an influx of particularly migrant workers, so Mozambicans working in South Africa in mining and other industries return home. And so we were able to work together with community leaders, with change agents, and with other sectors to be able to map those communities that were receiving high numbers. And eventually we were able to implement more sophisticated mechanisms in identifying communities with high levels of return, which again, then shifted how we focus our resources.
Keith, thank you very much. It is great experience, great program, and thank you for sharing with us. I have another question in terms of we have heard how much adaptation you have placed in the project. What have been major success, setback, or challenges for adapting community health programming to the COVID?
Yeah, good question. I mean, first I think I'll focus on the challenges because there have been many. I mean, I paint a picture like it was easy and we adapted overnight, but it's not true. It took time, and definitely the first point I made around looking after your own staff and community agents or volunteers is really important, and that took time. I mean, people didn't want to come back to work to begin with. They were scared. There was a hesitance. I know everyone likes to say, you know, communities are ready to go back there and in there, but there are a lot of demands on people. And particularly if you're reliant on volunteers, you know, they are seeking ways to support themselves in other ways. And often that also comes to the forefront in such a circumstance. I mean, particularly in this region, because we had such strict lockdowns in many countries around movement. Yes, essential staff were allowed to move and they could be essential health staff, but not all community health volunteers are recognized as essential health staff. And there are different layers of verifying this, and it's important to recognize that sometimes, you know, that doesn't allow us to always mobilize the resources that we need. So I think that took time and we found ways to work around it. And I spoke about some of the ways in terms of use of social media. And I think particularly using, you know, working with young migrants and mobile populations, it's a very popular and effective tool. So, you know, so we did look for solutions around that. I did mention some of the work, for example, in Mozambique around using population mobility data to direct the way that community programs invest in certain areas. But it's important to say that many countries don't have this in place. I mean, as IOM, we've been working on the issue of mobility and migration and health for many years in the regions. So we do have, you know, good examples and partnerships in communities where we have such mechanisms to track mobility in place. But, you know, that's not all communities. And I think, you know, at many points, governments have struggled with the inclusion of mobile populations and migrants in their COVID response plans. And that really starts with the first point of, do we know the trends of mobility, and do we have mechanisms to track those in real time? So while it is a good example of how we can respond effectively, I think it's a huge challenge in how do we instigate those mechanisms as routine mechanisms that allow us to better refine the way that we invest our interventions. Other challenges when talking about migrants and mobile populations, and you've probably seen it in many contexts, there's a huge reliance on borders and points of entry, and that real investment at official points of entry. But one thing that we've seen and communities have struggle with is, you know, we see a lot of porous borders in the region and a lot of movement that is irregular and not always regular through official points. So we know that this movement is happening, and while many of the COVID response plans have focused on those official points, we're seeing the impacts elsewhere. I mean, some of the ways in which we've responded to that, and I think is a good practice, and good practice that we've pulled particularly from West Africa and experiences as part of the Ebola outbreak there, was the investment in community events-based surveillance, particularly in border areas. So again, another community-based intervention, but really recognizing that, you know, people move in various ways, and it's really communities that feel the impact and take on the burden, and so that we need to have more diverse, I guess, approaches to strengthening the resilience of those communities. Other challenges, I guess, one that's emerging and it's different in every context is that around stigma, and stigma towards non-nationals. And I think it's something we need to keep a close eye on as we move forward, and particularly in this region as borders reopen, and we know that there's going to be an ongoing threat of reintroduction, particularly for countries that have gotten their epidemic under control. And so with that, and it's not new, and we've seen it with HIV, and we've seen it with TB and other diseases, is how do we balance those narratives around travellers, around non-nationals circulating in the country and the risks that they pose.
Keith Leung, thank you for sharing with us this experience, the adaptation of community health programming in the context of COVID-19. Thank you for being with us today, and I hope to see you soon.
Thanks so much. Bye.
Bye.